So we're going to talk about the concept of inflammation and how it relates to appendicitis and inflammatory bowel disease. This is just a reminder that the concept of inflammation means it's your body's immune response to an actual perceived threat. So it could be an actual threat like virus or a bacteria, or it could be a perceived threat like, cats or strawberries or something that you're allergic to that starts this inflammatory process. So what happens first is the blood vessels, once you're exposed to this threat, your blood vessels will start to constrict. Histamine is going to be released along with some other chemicals that dilate your blood vessels. And they rush a lot of blood to that specific area, wherever it may be, and that causes swelling. Then you're going to have fluids, proteins, white blood cells flood to that area and release from the bloodstream, and that's going to cause further swelling and some irritation in that area, maybe even pain. Eventually, if those things continue, they're going to start to form exudate, which is pus. You're also afterwards going to form some scar tissue when that fibrous tissue replaces the tissue that's been inflamed. So that's the process of inflammation. So for the first one, appendicitis has to do with your appendix, when your appendix becomes inflamed. So this is this little appendage that hangs off the end of your small intestine. We used to not really know what it was for, but now, there's some studies that show maybe it's a reservoir for your normal flora. Well, whatever the purpose of it is, you can definitely live without it, and sometimes it can cause problems. When food or mucus or something gets stuck inside of this appendix and it becomes inflamed, it can become so inflamed that it gets infected. It can even rupture and cause peritonitis, which is when all of your bowel contents, once it's ruptured, just start to leak into your peritoneal cavity. So that's definitely not something that we want to happen. So this is a pretty common thing that you'll probably see if you work on a medical surgical unit. It has some pretty classic symptoms that you'll see. The most common thing that you'll see is that right lower quadrant pain. So initially when that inflammatory process starts, it's kind of comes and goes in waves. It's pretty diffuse, just your belly hurts. And then as it gets worse, it becomes localized to that right lower quadrant. And it's extremely painful. So the person's going to probably report 10 out of 10 pain, by the time it's become really inflamed. They're going to be curled up in the fetal position. They're not going to want to lay flat. They're not going to want you to touch that area. If you do press on that area, you may notice something called rebound tenderness, which is when you press down, there's not a lot of pain, but when you release your hand, that's when they get a lot of pain. We call that rebound tenderness. They may also have fever, a loss of appetite. You might see some nausea and vomiting. As the swelling progresses, that abdomen is going to get really, really rigid. And again, you're going to notice that they're curled up in the fetal position, and they really don't want to flatten out at all. It's really uncomfortable. So we make our diagnosis first on that physical exam with those really classic symptoms that you'll see, that right lower quadrant pain, which is what we call McBurney's point, and some of those other symptoms that we just talked about. We're also going to look at their lab work. They may have a very high white cell count, especially if they have a ruptured appendix and it's turning into peritonitis. Then we're going to see that they're getting very, very sick. And you may notice something called a left shift when you look at their white cell count, which just means that they have a lot of immature white blood cells. Your body's trying to pump out white blood cells as fast as it can, so you'll see greater than 75% of those white blood cells are neutrophils. You may also see something called bandemia, when there's greater than 7% bands. These are way immature. Just think about, we're kicking these white blood cells out before they've even gotten out of diapers. They're not even functioning yet, and we're trying to kick them out. Diagnostic tests, we may do an x-ray, we may do a CAT scan or an ultrasound really our definitive diagnosis is going to come from that CAT scan. That's probably the #1 diagnostic test that you're going to see when it comes to this. If we do suspect that peritonitis, we may also get some blood cultures and a lactic acid level to see if they're becoming septic. So something you really want to watch for if you have a patient with appendicitis is if they suddenly say that they feel better and that their pain is relieved. That might indicate that that appendix has ruptured because they have so much pressure in that one area. When it ruptures, initially it's going to feel better. But then that means that whatever was in that area is now leaking into that sterile peritoneal cavity. So that's a big problem. If they suddenly report to you that they feel much better, you should be calling the provider about that. That's pretty serious. So our treatment for this is going to be surgical. We have to get rid of that appendix. Hopefully we can do that laparoscopically, where we're just making a few small incisions. This would be called an appendectomy. If it has ruptured, and especially if they have peritonitis, we may have to do an open appendectomy, where we're opening them up and cleaning out some of that, bowel movement or whatever has leaked into the abdomen, because the longer that sits there, the more severe that peritonitis is going to get. This is really an emergency surgery. This is not something that we're sitting on the person for a couple weeks on. If they're coming in at night, we're usually calling the OR team in. We want to get this done as soon as possible because we want to prevent that peritonitis from happening. So some complications if they don't have surgery in time, of course, that perforation, which then leads to peritonitis. And here's some really gnarly looking pictures that kind of show you what an appendix will look like when it's inflamed and when it ruptures. So let's get into the inflammatory bowel diseases. So we're going to talk about 2 of them, Crohn's disease and ulcerative colitis. So we'll go over Crohn's first. So Crohn's involves the entire alimentary canal from your mouth to your anus and anything in between. So it could be, you could see some of it in your mouth, large intestine, small intestine. The primary place that we're going to see this is in the small intestine. The inflammation extends through the entire bowel wall. The bowel starts to thicken as it scars up. That scar tissue starts to form, so it loses flexibility. So you want the tissue to be real pliable and smooth and wet, and now it looks more like cobblestone. And that prevents absorption of nutrients. So this person's going to be very malnourished. Our clinical manifestations, again, you see that right lower quadrant pain, but this is chronic, unlike appendicitis, which is acute. They're going to be crampy, they're going to have lots of semi-formed stools, possibly diarrhea, 6 to 8 times a day. It's going to be real mucousy and pussy, but you rarely will see blood with Crohn's disease. If they have a lot of inflammation in that area, you may even feel a mass down there. They may have fever, especially if they're having an exacerbation of this, fatigue, malaise, which just means they're not feeling well. Because they have all that diarrhea and malabsorption, they're going to have some weight loss and possibly anemia. And then a fistula is when there's an opening between 2 organs that are not compatible with each other, so you may see that happen with the bowel in the bladder or the bowel in the vagina. That can lead to infections, and it's just really uncomfortable. So something to remember about both of these inflammatory bowel diseases is that they are autoimmune diseases. So this is something the person's going to be dealing with for a lifetime. There's really no cure. We just have to treat them and try to get them into remission and keep them in remission as long as possible. Ulcerative colitis can involve the colon, specifically usually the rectum and the sigmoid colon, but it can involve the entire colon. So just think ulcerative colitis, colon. And this only affects the mucosa and the submucosa, but I don't want you to think that this is any less serious than Crohn's disease. This person sometimes is very ill. They can have diarrhea 5 to 30 times a day. So they're spending their entire day in the bathroom. the bowel tissue can start to hemorrhage, so you may see bloody stools. They may have some left lower quadrant pain, which is relieved with defecation. They're also going to have that malnourished state and that malabsorption, so you may see that anemia again. You may see low albumin. They just have a hard time pulling nutrients because they're going to the bathroom so frequently. Their white count may be up. Sometimes see really severe weight loss with both of these patients. And then the uveitis is an inflammation of the middle layer of the eye, so you may see the eyes get really red. So we diagnose both of these by doing a few different things. We'll look at their lab work. The CBC may show us that they're anemic. That BMP may be off because they're having this frequent diarrhea, so those electrolytes they may be low. You might see low potassium, low sodium, just low everything. Because that malnourished state is happening, you may see a low albumin and a low protein. Sedimentation rate tells us if there's inflammation going on inside of the body. It's pretty non-specific, but it will be elevated because of all that inflammation in the bowel. You may see LFTs high if they have inflammation in their bile duct. So that's called cholangitis, so that can raise the liver functions. We may take a look at the stool just to see if there's any mucus or infection in there or anything else that could be causing this massive amount of diarrhea, like C. diff, for example. We want to rule out anything else. And then really our definitive diagnosis is going to come from the sigmoidoscopy, colonoscopy, or EGD. We're going to take an actual look at the bowel tissue. They may take a sample of it just to see, how damaged it is. We could also do a barium enema, which would show us the mucosal patterns and the depth of damage. So our treatment for IBD is really from the bottom up. We want to try to, like I said, get this person in remission and keep them there as long as possible. So we may start out by giving them aminosalicylates. So examples of common ones are sulfasalazine and mesalamine. Those are the two common ones that you'll see. We may also give antibiotics, ones that work really well on the gut, like ciprofloxacin or metronidazole. As the disease progresses, we may have to sometimes give corticosteroids. We'll go over corticosteroids a lot this semester because they work really well in reducing inflammation and getting the person into remission. But long-term use of corticosteroids is very damaging to the body. It can cause blood sugars to be high. It can cause damage to the GI system, GI upset, can cause GI bleeds. Long-term use of corticosteroids can cause osteoporosis. So like I said, we'll go over this a little bit more in class, but just know that steroids are great, but they can also have a lot of really damaging effects too. Immunomodulators are sometimes called immunosuppressants. They modulate the immune system, but they also suppress the immune system, so just think of it that way. So when we talked in the previous module about neutropenic precautions, just think about this person is someone that we're intentionally suppressing the immune system of. So they're going to be at high risk for infection. So all of those neutropenic precautions that we talked about also apply to this person. Avoiding crowds, being careful with what they eat, like no fresh fruits or vegetables, pepper, paprika, raw fish, no sharing of bathroom supplies. Those things become really important with somebody that has no immune system.